So I want to thank everybody for coming. My name is Bob Sutherland. I am the founder and president of the Robert D. Sutherland Memorial Foundation. We are a Colorado nonprofit that has been around for about 16 years. The Sutherland Foundation works in partnership with the University of Colorado to provide comprehensive care to people with bipolar disorder. We make a local and national effect on that cause. It's truly inspiring for me to see so many people gathered here for this. I think we could suffice to say that we all have a common bond in our concern and interest in the cause of better mental health care in the community. The goal of this event is to allow you to hear from some of the top professionals in the field of bipolar treatment and to meet others like yourselves who care about the RDS Foundation's mission, which is better outcomes for people with bipolar disorder. We might even raise some money to support this crucial goal. As briefly as I can, I will introduce our esteemed and dedicated board of directors. Please stand when I introduce you. Rachel Cruz, probably out working somewhere. Rachel is our executive director. She is the driving force behind the organization. She's an organizational and communications professional who's been with the foundation for 8 years. You will be hearing from her later. Latimer reps, please stand Lat. Lat has played key roles in the Longmont Community Foundation, Habitat for Humanity, Community Youth Services, local economic development councils, and the National Aeronautics and Space Administration, although I'm sorry to say he's not an astronaut. Amy Metz. Amy is a development professional and realtor who was working for the University of Colorado Foundation before she joined our board. She is passionate about the cause of mental health care. Linda Kane. Linda went to work as a travel agent at a travel agency in Boulder in the 70s as a way to put herself through college. She is now the owner and president of Kane Travel, which happens to be the largest woman-owned business in Boulder County. Like many here, Linda has taken her family's difficult experience with bipolar disorder as a call to arms. Julie Immick. Like most RDS volunteers, Julie has a close family association with mental health. She is an accomplished specialist in organizational strategy who serves on the Foundation's executive committee. Lance Powers. Lance is based in Denver. He is a successful startup founder and a suicide survivor with a diagnosis of bipolar 1. He is a confidant to many tech employees and entrepreneurs about things that don't usually get discussed in that world. Kristen Bellion is the newest member of our board. She has served on the board of Women in Wilderness, Boulder Community Foundation, and Planned Parenthood, among others. Please give them all one more little round of applause. I can assure you that the other 364 days a year are nothing but selfless toil for all of them. I would now like to introduce the director of the Sutherland Bipolar Center, Dr. Alicia Bross. Alicia has been the most dedicated and hardworking member of our team since our inception in 2000. She is a PhD clinical psychologist and the author of a recent book on sleep disorders. A special mention has to go to David Miklowitz, who's one of our panel in the purple shirt. He is our senior clinical advisor to the Sutherland Center and has been involved since our inception. As a leading researcher and writer on bipolar treatment, David has been the architect of the Sutherland Center's approach to treatment and education. Thank you for making the trip all the way from Los Angeles. So David, Alicia, and I have been working together on the cause of better mental health care in Colorado for 16 years. And for me, this next and final introduction is very gratifying. We are honored to welcome Jeannie Ritter as MC and moderator of our panel discussion. Jeannie is married to Bill Ritter, the former governor of Colorado. It's all true, Jeannie. During her time as Colorado's First Lady, I actually prefer first person, she tirelessly advocated for the cause of mental health. She is currently the mental health ambassador for the Mental Health Center of Denver and is perhaps the leading public advocate for mental health in Colorado. She too has a close family association with bipolar. My favorite of her quotes, which I found online, is, "We're all in this together." Ain't that the truth? Jeannie, I gratefully cede the floor to you.
Wow, this is quite a group. I'm really, how do you take it when somebody in the group says, in the crowd says to me, "I'm so glad to see you're still around." I was like, So I think we can all agree. I recognize many of you as big fans of the Sutherland Foundation, but also there's new people in the crowd, and I'm really heartened. I've been saying we have a really sophisticated community out there. People are curious, and many of us were talking about how the level of this conversation just keeps getting deeper and broader. And so I appreciate all of you coming in today. How's breakfast? Pretty good, huh? Not a bad spicy burrito. Only in Colorado, right? But I'm going to give very brief introductions here. I want to encourage people to go to what's called the SBC Connection. I know you've gotten those newsletters, the Sutherland Bipolar Connection, Clinic Connection, or Center, and you'll get much deeper bios of the panelists here, which I'm not going to do justice to. It would be using up our time to read about what significant contributions they've already made, and I'd rather have time where we can kind of engage them, you can ask questions, and we can really get what we came for. One thing I want to, a couple of things, there's a little green sheet of paper in front of everybody, and it says that our contributions today will be matched by 100%. It's 125%. So it's, yeah, whoa, can we hear that? Oh, did you hear that? That means they're all bumping up. And so, I thought, we're here to raise money. We're here, the last 7 years, we've been trying to raise money for the center. And so that's why we're gathered. And we want to make sure that we send a clear message about the value of a program like this. I was really heartened when I got to be on some of the initial calls, and it was like, let's really get some leading edge stuff to put in front of people. And man, all bets are off. I mean, I'm telling you, just get ready with your questions. Very quickly, I don't have, I guess I could do this in order. Will Derveer is here in Boulder as well. His piece is on novel substances, and I'm like, you gotta give me more than that. But it's going to be very interesting. If I had to pick a favorite, no offense, it's going to be Will. So my question is going to go to Will. But Will is using ketamine. He's going to enlighten us a bit more on some of the new research and science around things we can use. Debbie Boeldt, can I get away from Debbie? So Debbie is here, and she's going to be talking about web-based services, digital health, and she's going to touch on mindfulness for us. But she's a clinical researcher. Again, these are all doctors, and I mean, it's really lofty up here. Matt, another favorite of mine, I'm really privileged to sit on the National Mental Health Innovations Center board with Matt out at the Anschutz, and I'll tell you, Matt leaves nothing out of this conversation, so that won't be a surprise either. Technology, real-life settings. Dr. Suddath is the transcranial magnetic stimulator guy, and he's going to talk to us about that. Well, I mean, you're much more than that, of course, but it's, again, this is stuff that maybe has been around, but kind of, I think, the nuances around this and how we normalize some of these treatments and get them into the mainstream and actually get lay people, of course most of you are psychiatrists, we realize, but anyway, but get lay people able to talk about what this is and the impact it has. And then finally, Dr. Miklowitz, I told him earlier, he was a part of my formation, right? I was this kind of perky first lady that thought we should be talking about mental health, and you were really, I remember really being on the phone with you, and I'm just so proud and pleased that I got to have an intersection early on with this level of leadership. So let's have at it. We're going to make the best of our time. They have about 4 minutes, and we really kept them to 4 slides, which people, you know, and they can't do 4 slides, so we'll see how well they did. But we really are going to get the essence of what you're talking about, and then we're going to open this up. And I have some lofty questions that were crafted in case it's a quiet audience, but I don't think you'll disappoint me. So who wants to start? Will, do you want to open up? Let's try it. That'd be great. Or do we have to go with what you guys? Oh, we have this all teed up. Dr. Miklowitz is our first clue. Beautiful. Okay, great.
Thanks very much for having me here. My first question when I got up this morning was, how was I going to wake my brain up enough to do a 4-minute talk and summarize my career in 4 minutes? Fortunately, Dr. Suddath here tried transcranial magnetic stimulation on me, and it worked very well, so I'm now awake. Anyway, it's my pleasure to be here. Going back to 1999 is when I first met the Sutherlands, and we talked about setting up both a clinic and a training program for people with bipolar disorder. It's amazing to me to see how much it's moved forward in the time with Alicia Bloss's stewardship, and a lot of people put a lot of time into it. So I've been asked to talk very quickly about my area of expertise. Some of you know me. My area is on family processes, and specifically, what does the family have to do with bipolar disorder? How are people with the disorder affected? How do they affect their families? And how do family members affect the person with bipolar disorder? Trying to understand that interaction. And in turn, developing treatments that might address stress and burden within families in a way that might produce better outcomes. Next slide, please. Is there someone? Okay, so our treatment is called Family Focused Treatment, FFT, which is we've given it in various dosages, 12 sessions, 21 sessions. I believe the Sutherland program does 12. I could be wrong about that. But the idea is not so much the number of sessions, but to bring in the person with the disorder and their relatives, whether that be parents, siblings, a spouse, and teach the family in a way they can understand what do we know about bipolar disorder, what triggers it, what do we know about what factors protect people from relapse, using that person's experience, what led to your last recurrence. We point out some of the triggers for when you ended up in the hospital. What could have gone differently in your family? The idea is to decrease friction within the family and increase resilience, better communication, a more supportive environment for the family in a way that can help both patients and relatives. Next. So what do we know about this treatment? This treatment, like I said, involves psychoeducation about the bipolar disorder, its signs and symptoms, how to recognize recurrences. Later on, we talk about communication strategies, how to improve person-to-person communication, how to solve problems that come up in families that could take different forms in different families, depending upon their existing level of skill. But what we're finding is that when you combine family-focused treatment with a typical medication regimen for bipolar disorder, you get a much better outcome over time, fewer recurrences, better functioning between episodes, higher psychosocial functioning than you do with either medications alone or medications with supportive individual therapy. So we do have reason to think this is an evidence-based therapy, and much what has been done at the Suddath Center has shown that. We're more recently getting into the area of early intervention. It turns out you can identify kids who are at risk for having bipolar disorder in a couple of ways. One is to look for children who have bipolar parents, who have established bipolar disorder, kids who have mood swings, early signs of depression, suicidality sometimes, anxiety, dysregulated moods, not surprisingly. And these kids are at increased risk. Some would say up to 50% chance of developing bipolar disorder by the time they're 15 or 16. We've targeted that group for early intervention. So we do a version of family-focused therapy with kids who are only 9 or 10 or 11 with their family members. And the purpose of these studies is, over the long term, going to be, can we prevent bipolar disorder in a kid who's at risk? I think I have one more slide. So why is this important? First, in our experience, families' needs are ignored by the mental health profession. That's getting better. We're seeing more psychoeducation programs, workshops, books written for family members. But when I started this work, there really wasn't anything for families of bipolar patients. There was a lot for schizophrenia, but nothing really for bipolar disorder. And what we want to be able to do is enhance family environments to keep them protective, and we hope this is going to have a role in the long term in preventing the disorder, or at least figuring out whether we can reduce its severity once it's manifest. So I thank the Suddath Center for all your hard work and keeping us afloat all these years, training all of our students, Alicia Ross, and very happy to be here. Thank you.
Not bad, flying in 4 minutes, brilliant, really nice. So next we have Debbie Boeldt. Debbie, if you want to come up, and that was a great opening, Dr. Miklowitz. Thank you.
Good morning, everyone. I am just incredibly grateful to be here. The opportunity to see David after so many years. My first graduate level class was taught by him at Stephen Boulder. And then I was also a trainee in the Suddath Center. And so I'm a clinical psychologist by training. I had a background in behavioral genetics, which then sent me on a slightly different path, where I ended up in genomics research as a postdoctoral fellow, which was an amazing opportunity that introduced me then to digital health. And so I was at the Scripps Translational Science Institute for my postdoc, learning about how digital health could help improve things around cardiovascular disease and a little bit around mindfulness and meditation, tracking how kind of physiological changes in a real-time environment. And so that part of my career kind of shifted when I went to a startup and was thrown into personalized medicine. And as a behavioral health person, I was brought on to help integrate the information that people receive back from either digital health or from their genomics, which is a great idea, except it was always the afterthought in terms of how kind of the clinics I was working in practice. So they weren't thinking about the user, the patient, the person at the front end of this whole process. They were thinking like, oh, we're going to give you all your DNA back and you're going to change your behavior, which we know it doesn't quite work that way. And so I had an opportunity to move back here to Colorado and to work with Sona Division at CU Boulder. and was able to bring my digital health expertise now back here and into the psychology department, working on web-based mindfulness programs. We're currently working on a program that's adapting mindfulness-based cognitive therapy for moms at risk of postpartum depression. And so I've been doing a lot of work around this in terms of engaging patient stakeholders and understanding how people use the technology. I think there tends to be this siloing effect of the industry and then the clinical and academia, and how we bridge all these pieces together is really essential and important. I guess next slide. And so just wanting to touch upon kind of what are the broad buckets of digital health. We think about this as self-reported, so this would be that survey coming to your phone as you fill it out. Either that or task-based, so these are the ones people you see walking around with their Fitbits trying to get their steps in. Versus active, so this would be more like glucometers that fit onto iPhones. More recently, just as of yesterday, the FDA approved the Abilified MySight, which is a pill designed by Proteus where you can actually track when people have taken their medications. So they take this pill, they wear a Band-Aid type thing on their stomach, and it will send a signal to their Bluetooth phone. And so there's those pieces, and then passive tracking. So you think of this as like sleep and those types of things. And so I'm going to focus a bit on the passive, just because this is an area where they've been developing some apps around bipolar disorder. And so a few years ago, MIT Media Lab developed a tool that they thought was going to help track flu on campuses, where they would geolocate, so they could tell if you were leaving your dorm room, they could tell if you were answering your phone, if you were texting, if you were just surfing Facebook all day long, all these different aspects, and they were planning to see if they would be able to track where flu was on campus and whatnot, and they realized they were actually tracking depression. So people were using, answering calls less, responding less, not leaving their dorm room, maybe not even picking up their phones, so sleeping more, sleeping less. You can track when lights are on from cell phones. And so all of these pieces, and so they spun that out into a company now where they're building this into more telehealth and teletherapy. And so a group where they have psychologists, psychiatrists, and health coaches all online who can then use this quantitative measure of kind of their behavior in addition to self-report. I don't think we should get rid of self-report anytime soon, but in terms of like having a quantitative way of measuring. Next slide. So why is this important? It provides actually, I think we skipped one. That's all right. So again, just the quantitative measurement. But in terms of the more specific app I wanted to talk about, because I am an app junkie, is the something called Buy Half Fact. What they're doing with this app is they will be using that money to continue to hone it and make sure that it's effective, and then they will be putting it in the App Store for people to download. And the idea is that you can track things around keystroke dynamics, so how quickly someone's texting, how long their texts are, how many errors there are in the text, and then there's other pieces you can track, but they're not quite there yet. There's some other issues that come up around that. But so this is something that's, from a clinical standpoint, I think another useful tool that clinicians can use and patients can use to be more proactive about noticing when those subtle changes in the moods are occurring. And so this app is something that they've been working on for the past several years, but is something that I think could be a beneficial tool. However, there are caveats to all of this. When I looked up the news article last night around the FDA, you know, every time something like this comes out, there's always the term Big Brother in one of the titles. And so there really is, my training was in bioethics around genomics, but there's a lot of parallels with digital health in terms of making sure people's data is secure, doing this in a really rigorous and responsible way, and also just creating a transparent communication with patients around this, because I think, you know, making sure they know where their data is stored. You know, it's really important now with HIPAA compliance to make sure that you have clouds that are storing this data, that things are built directly into the app, that you're not emailing or texting them directly, different things like that. And then there's also the security piece, but the bioethic piece around like, do you want your data stored? Do you want this information collected for you? And I don't think it's a one-size-fits-all. I think that's why I've been doing the research I work on is really around personalizing, like using things to a level that you feel comfortable with. And then efficacy issues. I mean, bioethics has had a few pilot studies, but definitely needs a lot more research just to make sure that we are tracking what we think we're tracking and to see what those effects are for participants who use this app to track their mood. Next slide. And so I think there's this real benefit to real-time tracking. I think in terms of just self-monitoring and being able to keep track of how you're doing, and again, this proactive versus reactive, like being able to notice those subtle changes in your moods as they occur. Similarly, helping to empower patients and clients and people to just track their own behavior. And I think also, I've been thinking about this a bit in terms of how family members can help. A lot around FFT and what I've learned in my past trainings. It was making sure that you have that support around you, and if there's a way, especially for adolescents or kids, in terms of their parents having access to this type of information. So maybe the kid isn't tracking, but maybe the parents can keep an eye on it. Similarly for the clinician, when they come in every week, I used to do the old school thing where I'd enter numbers in Excel and then show someone their graph. And it was powerful to show someone that, like, look, your mood is improving, or what happened here, it gives you a jumping point to discuss. So I'm just really thankful to have the opportunity to tell you a bit about the technology that I'm passionate about, but would love to discuss more at some point about the mindfulness specific stuff too. Thank you.
Didn't I say leading edge? And she's telling us what was approved by the FDA yesterday. So you're in the room. Thank you very much. This is I can see who's up next. It's kind of like Christmas, like who's up next? I mean, your hand should be itching by now to have some questions. So I really appreciate this opportunity. I hope it's not lost on anyone here to have this caliber of folks presenting to us at a pace like this. So thank you. Matt, show us what you got. Can you top that?
So I want to thank you for having me back this year. I was able to have the honor of speaking at this event last year, and when they called you to invite me back, I thought, wow, I didn't suck. So it's an honor to be here again, and it's really a humbling honor to be part of this panel. I look down this line and think if I could be half as smart as any one of these people, I would be a happy guy. So I really appreciate that. The good news is I talk really, really fast, so I can fit 8 minutes into 4. So fasten your seatbelts. But in terms of the area of expertise, expert is a label that I sort of cringe at and go to great lengths to not self-apply. But I will say that our center is filled with people that I think are just incredible experts in their field, and that gets even better on December 1 when Debbie joins our staff half-time. So super, super great. So I'm claiming your expertise is mine. Our center is really dedicated to how do we get innovative approaches out into the real world. So we're not a typical research center. We're really focused on everything ranging from how can we support other organizations in implementing and trying to validate and develop new treatment approaches, but really have expanded that, so a great deal of our work is in the prevention and early intervention arena, because that's consistent with my background as a public health person. So it's kind of a relatively new concept in public health to focus on mental health. There's actually only 5 master programs in the country in public health that focus on mental health. So it's exciting to have a center that's able to do that. So I'm trying to look through Will. So you can go to the next slide. So our general area of innovation, we're looking at a lot of different ways of of treating and preventing. And one of the ones that I want to highlight today is the use of virtual reality in treating bipolar and really in the related conditions. And that's where the field is right now. And I think it's still an unknown exactly how virtual reality will play out as a treatment for bipolar itself. But certainly we know that it's very effective for some of the related conditions like anxiety and depression. And there is good emerging data on that I'll talk about in a moment. But there's definitely a need for more. Some of the great data is that we know that it is very effective as a tool for helping people meditate. And one of the biggest things that people say is an obstacle to meditation is, I just can't shut out the outside world. And VR is really good at doing that for you. So if you want to, instead of meditating in your room with the kids running around, you can put yourself on a beach or in a jungle or in a Buddhist temple or in any number of places to enhance that experience. And there's data, and we're hearing from a lot of people that have tried it as a result of our center. They're finding it much easier to meditate and much easier to stick with it using virtual immersive environments. And then we're working with private industry to help them develop new approaches. And this is a bit unusual and kind of atypical, especially for a university center, to work closely with industry as we are. But we realized what's happened is that in the last 2 years in virtual reality, there's been an explosion on the field as this stuff has finally become available in a cost-effective way. For 30 years, virtual reality headsets were about the size of this podium, and you would put them on people's heads, and they actually had to counterbalance them with bricks because it was like having a TV set strapped to your face. Not great for very long. Now that it is there, we have people who say, oh, there's money to be made. And so you have software companies and startups left and right who say, oh, the video game field is crowded. Well, what else can VR do? Oh, mental health, there's research in that, so we'll develop these products. Well, they're going to develop them whether we're with them or not. And they have venture capitalists who are pushing them to get things to market. And many of them are doing it in an irresponsible way. I'll call out Samsung as an example. They have aggressively marketing an anxiety treatment platform to treat your phobias. And they say it's backed by research that you can treat yourself at home and do exposure therapy in the comfort of your living room all by yourself. You don't need a therapist. And the only study, when you dig deeper, that they cite is one that they conducted with about 13 people. So there's a lot of people doing it irresponsibly, but we found that a lot of the companies really want to get it right. So we said, well, work with us. Let us help you develop content, to develop training, to develop clinical protocols, to think through how this is going to fit into a clinical environment, and how do we give therapists the training and the tools to be able to use this technology to guide patients through the treatment. Next slide. So the present state of evidence, there's about 30 years of research on virtual reality. A lot of people don't realize that. In terms of all kinds of areas of behavior change, everything from treating functional neurologic disorders like MS and Parkinson's disease to stroke rehab, pain management, anxiety disorders, PTSD, a variety of applications. But the problem with the research is that most of it was done in university settings on old equipment that doesn't exist anymore, stuff that was very big and heavy and cumbersome. And because it was limited availability, most of the studies were done with college undergrads who were doing it, for pizza and beer money, doing these studies. So we have small ends and very homogeneous populations. So there's really a need now with the technology available to do much bigger studies with larger ends to validate some of what we've learned in those early trials. But we do know that it's effective in a variety of settings, and there's, as I had mentioned, and there's new research now being done left and right. It's becoming a very big field because people realize the potential and the power of VR as a treatment modality for bipolar and depression and all sorts of other mental illnesses. But we know that our favorite line in the university world is that further study is needed. And in this case, it is very, very much true. Next slide. So why is it important? Well, I think the obvious answer is that the more things that providers have in their toolbox, the better off they'll be. We know that no mood stabilizer works for every single person with bipolar. People respond differently to different therapies. And the more that we can have things like family-focused therapy, transcranial magnetic stimulation, apps, and now virtual reality into the toolbox, the more likely that we're going to be able to find something that's a fit for every patient. And that really is the key to helping people get better, is finding something for everyone. Because with any of these treatments, your mileage may vary, as I think everybody in this room knows. That we know that powerful technologies can be highly effective. And we also know that if we don't get involved, if we don't help validate some of the products that these Silicon Valley companies are creating, and we're going to be in big trouble, because the chances of them doing it wrong and having stuff out there that could actually potentially even cause harm rather than do good becomes much, much greater. Thank you.
Thank you, Matt. And those of you with your checkbooks out, we still have 2 more to go. So don't write your check yet. Who do we have up? Oh, Dr. Richards. So thank you so much.
It's a pleasure to be here and an honor to be invited. And I've been involved with the Suddath Center in one way or another since probably early 90s. David and I met back then. My background was at NIH. I'm a psychiatrist at NIH in brain imaging, mostly neuroanatomical brain imaging with MRI. And when I came here, I began to work on dealing with neuropsychiatric conditions and started being referred a lot of patients with treatment-resistant depression. So in recent years, I'd say since about 2010, I'm going to say we because I'm including my co-medical director in the Boeldt Center for TMS, Earl Sugarman, and our staff became interested in using TMS for treating treatment-resistant depression. And this is really a very elegant treatment in many ways, and I just want to explain how the procedure is done. It uses a magnetic pulse similar to the strength of an MRI, but it's in a coil and encased in plastic. So basically, you start off over the motor cortex on the left side, which is above the left ear. And what you're trying to do is find the spot to get the right thumb to move, which tells you where you are anatomically. Because the motor strip for the whole body is kind of laid out over that strip above the ear. So once you know where you are relative to a specific muscle, you get that to move, then you find the pulse strength that is the least, so the least intensity required to get the thumb to move. And that becomes what's called the motor threshold. The treatment is then done over a part of the left frontal area, which is called the left dorsolateral prefrontal cortex, which just means it's dorsal and lateral to the medial part of the brain. The treatment itself involves pulses that are 10 pulses per second for 4 seconds. And then that repeats every 30 seconds. So basically over the course of about 37 minutes, you're getting about 3,000 pulses. The effect of this is to upregulate that part of the brain. So it's been found in studies using brain imaging that this part of the brain is underactive in depression, using blood flow by PET scans or SPECT scans. That protocol has been worked out over many, many years and is now FDA approved. When you look at the neurobiology of depression, what's going on in the brain in depression, there are many ways to look at that, and probably all of them have some element of truth. When you look at the brain in terms of neurocircuitry and what circuits are more active, what are less active, one interesting finding of how TMS might work relates to boosting brain-derived neurotrophic factor, which is the major growth factor in the brain. It's involved somewhat in new neuronal growth, but also in maintaining synaptic neuroplasticity. So this treatment actually increases production of that growth factor. The other effect is rebalancing circuits that have been found to be out of balance in depression. And I think one of the exciting things about where we are right now is having the ability for the first time in human history, to simultaneously stimulate the brain with a TMS while the person's in a functional MRI system, and you can see what happens in the brain when you stimulate one area and then how another area responds. And there's an incredibly elegant paper that was done, or study that was done involving like Harvard, Stanford, Emory, and several other sites, where they looked at functional connectivity in depression, and they found that there were 2 areas that were particularly replicable, and based on that, they defined 4 abnormal patterns in depression, and they found that these 4 patterns didn't seem to have any clear clinical subtype, so you couldn't predict the pattern based on the symptoms the person had. They all had feelings of depressed mood and worthlessness and hopelessness. But using this technique, they looked at MRI, at TMS, and found that 2 of these areas had a very high response rate to TMS. One was in the range of about 90%, and the other was in the range of mid-60%. And the 2 other areas only had a response rate of about 20%. So I think that sort of real life, real moment imaging with the capacity to differentiate on a biological basis different depressive subtypes is really unique. I think it really shows a huge amount of cooperation between the top centers in the country looking at that. In our clinic, we've treated so far about 230 patients over the past 7 years, and we estimate about 40% of those patients have some degree of bipolar disorder, some bipolar 1, bipolar 2, some patients with subsyndromal, mixed states that you may have heard about. And we feel like we've had some of the best responses have been in patients with, especially with bipolar 2, who have gotten to a point of not responding to antidepressants or other treatments. The treatment itself, you do 5 days a week for about 5 or 6 weeks. So one side effect is time, and the other is just the cost of it. But you can drive yourselves to and from the treatment, and people can typically go back to work after the treatment. The other thing I just wanted to touch on, and I know Will's going to speak more about this, which is very exciting, is the use of ketamine. Ketamine has been found to have fairly immediate antidepressant properties, and we started using this about 4 or 5 years ago in a nasal spray form. So I'd always treat the patient the first time in my office and then show them how to use it and administer it. And typically, it would be administered every other or every 3rd day. And often people would have an immediate response. They would be suicidal, hopeless, almost on the verge of needing to go in the hospital, and within minutes, be no longer suicidal. I also feel that we've seen a synergistic response between ketamine and TMS. Often combine those 2 when patients are particularly depressed, if they're willing to do that. So those are 2 treatments we've been doing for about 4 or 5 years that are, I think, very exciting. So I think with TMS in the future, what is innovative is I think there need to be more studies on bipolar disorder particularly. There are only really a handful and a very small number of subjects. So I think at this point, across the country, our clinical experience with using TMS for bipolar depression is way ahead of the literature. So I'll stop there.
Rachel, I think you totally blew this. Like,
We did.
We should have auctioned these people off for a dinner party or something. We had the potential to make big money. Okay, anyway, Will, we want to hear from you. Come on up.
It's an honor to be here, and I've been involved in the Suddath Center for, I think, about 15 years. And I just want to echo Jeannie's words about making this happen and keeping it going. This is such an important resource for people in our community. It's been really profound and meaningful for a number of our patients. So I want to thank everyone who's involved in continuing to fight a good fight and keep this alive and running. So I've been in practice for about 15 years in Boulder, and my career has been about looking for ways to enhance treatment response without relying only on medication. That's been a big focus in my clinic. So I pay attention to the gut-brain axis, the lifestyle changes, mindfulness, and all of the different levers that, as a clinician, I can pull to get results without exposing people to long-term medications unnecessarily. So I'm a fan of medication. I prescribe medication. I'm not anti-medication. But we all know that there are limits to medications and significant side effects that a lot of people have to deal with. So anything that I can do to reduce the burden of symptom reduction on the medications is good news to me. The other piece that I've been more recently interested in is the use of medications taken on the day of a treatment in order to enhance psychotherapy response. So I've always been a huge fan of Dr. Miklowitz's work and focusing on family therapy and individual therapy in the treatment of these serious illnesses, because I think psychotherapy oftentimes will really diminish the necessity of high-dose long-term medication. So in terms of enhancing psychotherapy response with medications, as an aside, I've been involved in a clinical trial. We're about to start a phase 3 study in Boulder, studying the use of MDMA with psychotherapy for PTSD. So out of that experience, which we had good success with, and I can talk more about that and hear about that later, I got interested in using ketamine as a facilitator of psychotherapy. And actually this went back 3 or 4 years back, and I called Richard because one of my patients came to me and said, hey, what do you think about ketamine for me? And he said, hey, we're using intranasal ketamine. So I'm just so grateful for Richard and the community for pioneering and moving things forward and having such a forward-looking attitude about treatment and being a resource for me and others in the community. Thank you. Next slide, please. Okay, so what I've been working with in the last year is using ketamine for bipolar depression and unipolar depression. One of the key elements of ketamine treatment, as Richard was talking about relating to TMS, is this brain-derived neurotropic factor. So BDNF is it's kind of a growth hormone for the brain. So it increases dendritic sprouting and enhances interconnectivity between synapses. So it makes neurons have more connectivity between each other. And we think that this is something that is a really fertile ground for psychotherapy. So in my work with ketamine, as it applies to bipolar disorder, the main thing that I found is that it can be a huge lifesaver in regards to acute suicidality, is one thing. So it's been a tool that I've been able to use to avert the necessity of ECT on a few occasions, and also in my effort to keep people out of the hospital. So it's something that definitely requires a lot more research. As Richard was saying, our clinical experience is out in front of the literature at this point. And we're not going to see a phase 3 study on ketamine because ketamine's been generic for about 40 years. There are companies that are developing analogs of ketamine, which are going to be patented compounds, which I welcome. I love having more tools available. But those patented compounds are going to be on patent, and they'll be expensive. And it'll be, there are 2 of them that are in a phase 3 clinical trial right now. So at least we'll have phase 3 data on these analogs, even though we probably won't see that with ketamine. The last thing I wanted to say, and forgive me for being a little bit ambitious with my slides, I wanted to talk about ketamine today, but I also wanted to talk about the big picture. One of the things I teach the residents in Denver in psychiatry, and also in a seminar that I do for psychiatrists, is the importance of lifestyle, gut health, diet, exercise, sleep hygiene. I recommend Alicia's book a lot in regards to that, so you guys should definitely check that out. The thing I wanted to say about gut, just in a nutshell, can I have the next slide, please? Is that we do have data on fish oil as a mood stabilizer. Okay, so I could talk for probably a weekend about died in God in bipolar disorder, but just suffice to say that fish oil is a useful mood stabilizer. That, again, we don't have enough data in terms of, phase 3 trials, and there is mixed data on fish oil, to be perfectly honest. But in my experience, using a high dose of the EPA component of fish oil on the order of 1.5 to 2 grams a day can have a significant impact on reliance on mood stabilizers in the long-term treatment of bipolar disorder. So I just wanted people to be aware that that is out there. And I just want to mention these other 2 studies while I'm here. Dr. Zarate at NIMH is the kind of chief pioneer of ketamine right now. And his study in 2006 was a single IV infusion study of ketamine. And 70% of the people who got one infusion had a 50% drop in their symptoms of depression. This was a mixed population of bipolar depression and unipolar depression. The problem with that study was that about 50% of the people had relapsed within a week. So the problem with ketamine is that we need to figure out how to make it last. And that's, I think, a big part of where the push in the research is right now. The Lowry study is another study which focused on specifically treatment-resistant bipolar depression. And I thought it was interesting that they were looking at a specific brain location called the anterior cingulate that's really involved in the symptom of anhedonia, which is the lack of pleasure, which is one of the harder treatments, one of the harder symptoms of depression to get a handle on. So they saw changes in the anterior cingulate that correlated with positive treatment response to ketamine. So bipolar depression is a difficult one to treat. For those of you in the audience who are providers or family members, you know that antidepressants are tricky in bipolar depression. And so Richard and I were just talking about how difficult it can be to find the right treatment for bipolar depression. When you run out of mood stabilizers, what do you do now? And do you take a risk of giving someone who's bipolar, who may be on 2 or 3 mood stabilizers and antidepressant at that point, and what are the potential risks and benefits of that? So that's where I think ketamine can be a really useful tool, because it doesn't stimulate the serotonin system. It works on a different neurotransmitter system called the NMDA receptors. And with these smaller studies, at least from NIMH, we know that in those studies, there was no one who became hypomanic or manic from the treatment with ketamine. So I feel pretty comfortable treating bipolar depression with ketamine because of that. Suicide is a huge problem, of course. Probably a lot of us in the room know people with bipolar who have suicided. I certainly have. And so having more tools available for us, I think makes the world a much better place, of course. Hospitalization and ECT are costly. I don't want to incur additional costs or additional side effects or potentially long-term disability from memory loss from ECT. If I can avoid it, I certainly refer people for ECT. Usually happens about once a year. But anything I can put in place, any stops on the train track before the final station of ECT, I'm happy to have. So next slide, please. Is that it? One more? Okay. Thanks very much.
So, I told you it wouldn't disappoint, so I want to thank all of you. We have a little bit of time. We still have a bit more to our program that is maybe not so cerebral, and only this has been really enjoyable. But I want to make sure we have. Can we take just a couple questions? We have just a couple questions.
So, I would like to know, is anyone in a hurry to leave? No. Okay, great. So we can go over 15 minutes, 9:45.
10 minutes, yeah. So let's just see. That would be, of course, the woman who's going to do the ask in the end. So she wants to make sure nobody's leaving early. We know how this works. So does anybody have a question? I think that'd be great if you could ask a question. It'd be great. And we're hoping that they're really questions. We want to avoid like a long story, but really make take advantage of who we have here on the stage, if you will. Thanks.
Thank you very much. So my question, I know it's already addressed with ketamine, but particularly with TMS and maybe the VR interventions, is there data available to show any potential risks of manic switching, similar to what we see in SSRI and monotherapy?
Yeah, so...
First, you have to translate the question.
Okay, the question is the risk of inducing activation or mania with either ketamine, TMS, or both. And I think, yes, the risk is there. We've seen switching with TMS, and we've seen some switching. I've seen switching with people only on ketamine in my private practice. I think what I like about both of those, though, is they can be terminated. In other words, the ketamine stays in your system a very short time. And also TMS, if you see some activation, you can stop it. As opposed to having an antidepressant that may take a month or more to get out of their system. There's also a lot we don't know about what happens when mania gets induced, and I think even worse is where persons develop severe mixed states and rapid cycling, which then requires getting off anything with antidepressant properties and maximizing mood stabilizers. And I've seen it take a year or 2 years with people on the strongest anti-manic drugs I could find to get that to stop. So that's, I think probably all of you are aware to some degree of that need to anticipate mania starting and stop the antidepressant. But all that being said, I think the risk is relatively low of that happening. And in the cases where we've had activation or outright manic symptoms start, and we stopped it, they went away within a few days.
Great question. Anybody?
I have a question. First of all, I just wanted to mention that unlike most of you or many of you, a lot of this was over my head because I'm not a psychiatrist or a psychologist, but I'm somebody living with bipolar 2. I don't know whether my question should go to Dr. Miklowitz or Dr. Derveer, but I was at a 3-day seminar in which I was the only person who was on medication. And Dr. Miklowitz, you made a comment about preventing bipolar in children. So I'd like a comment on that. But I also want to understand this whole notion that I heard, mental illness is not real, and you can be on no medication. If you're on medication, you can just give it up. And so I went to my psychiatrist and said, I want to give it up. And he said, why? You're being treated and you're very well treated. So it's kind of a question comment, and I don't know who the best to answer.
I'll take a stab at it. I think the first question is, what do we mean by people inheriting bipolar disorder from someone who has bipolar disorder? Am I summarizing that accurately?
He actually said prevention in children.
Okay. I usually call it early intervention. There is a technical difference. Prevention means at the population level you come in and you try to prevent an illness like heart disease, cancer, obesity. We don't have the technology to do prevention for bipolar disorder yet. We have to start before kids show any symptoms. What we do have are some early indicators, symptom-wise, of what kids look like if they're going to go on to bipolar disorder, such as moodiness, all the usual suspects, depression, anxiety. And those are the kids we target for treatment. About your second question about is it accurate to say people can get along without medications, I would say in most cases, no, they don't. They don't do well without medications. The majority of people, certainly with bipolar 1, need to be on mood stabilizers or second-generation antipsychotics. I'm delighted to hear there are options such as ketamine and TMS available, but that doesn't change the fact that there needs to be a medical intervention on board. The only time I've seen people with bipolar disorder who did okay off of medication were those with bipolar 2, where they had depression with hypomania. and maybe their depressions weren't that severe, or they had them once a year or two, and they didn't feel like they needed a full medication regimen. If it's a mild enough form of bipolar disorder, you may be able to get away without it.
I just want to add one quick thing to that. I would say that it's really dangerous to go off your medications without having a medical, person working with you. And in my practice, I think every case is individually different. So we have to look at what the missing resources are for that person. We have to set up the right circumstances to even look at the possibility of lowering medications. But it's a really deliberate and carefully planned out process to do any kind of medication taper. So I just wanted to say that I think that there are cases where people can eventually come off of medication, but oftentimes that process is really difficult and complicated. And it should always be done with the supervision of somebody who's taking care of that and looking out for the safety concerns.
We've got a couple more questions back there. Oh, great.
Can you hear me now? Okay. Thank you. So you all talked a lot about more of the interventions that can occur once people are actually able to go find treatment. And Matt and Debbie, you touched on this lightly, but can you just speak a little bit more about the cultural or social things that are stopping people from even getting to you in the first place?
I'm not a provider, but I will certainly say, both from my own personal experience and from having worked at the Depression Center for 8 years. Stigma is the number one thing. And so I think that I really believe in my own life and in many people that I've seen. I think we can never, ever let up in that fight. And I think that one of the exciting things, that being on a panel like this is everyone is doing such exciting work. And stigma gets addressed and effectively not by billboards or bus ads or things like that. Those things, the data is pretty clear that they're not real effective for real long periods of time. What addresses stigma is people with lived experience talking about it, and then people who are doing really amazing things in the field getting other people excited talking about it. And so I think events like this, or any opportunity that we have to talk about our work, to talk about our personal experiences, if there's one thing that any of us in this room, all of us in this room can do, is to engage as many people in conversations around this disease as possible.
Yeah, and I would just add that coming from the tech world, academia and psychologists in general are probably less accepting of technology, whereas we swing the other way in the technology world, which Matt spoke about, where they're running ahead, the technology's ahead of the science. And so I think there's a lot of ways that we can start to think about what works for certain people. And especially around telehealth, there's a lot of different options. There's actually fairly good evidence for even texting for therapy around, there's a couple different groups that have done a few studies on that. This is all still early, but ways that you can interact with your clinician, with your psychiatrist in a way that's a little less stigmatizing. Around telehealth, there's a group I worked with where a majority of the people who are coming in are men, or coming in to telehealth, are men, and part of that being that they can do it from the comfort of their own home. They don't have to, especially in rural areas, they don't see your car outside, Dr. So-and-so's office, those types of things that are helping people gain access more quickly, that I think we shouldn't discount, but I also think that there is a balance of the technology in the clinical work.
Another question maybe to you, Debbie, and maybe Matt, to the technical people here. Can you very concretely recommend some apps, websites, how to get to telehealth? Just give us, not as technically educated people, some very simple tools that we could pass on.
Sure, yeah. I don't know if it would be helpful to put together, I have a list, but just as local as Denver, IESO Health focuses on cognitive behavioral therapy and is an online chat platform. IESO, IESO, I mean, there's quite a few, and I'm hesitant to say them all right now because some are, I think, better vetted than others. But in terms of just thinking, like, I mean, there's different, I would say there aren't any necessarily geared towards, like, I don't want to speak to how well trained the psychologists or therapists are for bipolar disorder. That's kind of why I'm hesitating. But Ginger.io is the company that I was referencing earlier, who does the passive data collection.
Well, I guess I'd make a more general statement and say you've highlighted a big problem. You know, if you go to the App Store, there's 10 million apps out there for all sorts of mental health conditions. And how do we make decisions on them? We look at how many stars there are, and which is gibberish. I mean, those stars mean nothing. They're usually done by people that base it on, do I like the colors, or is the interface pretty? And they usually do those ratings after a day or two, just to get that little pop-up window to shut up. So they don't say anything about the evidence that's behind them or their long-term effectiveness. They also don't talk about how they're used either by yourself or in partnership with a therapist. And so I really think that if you have a provider, you should start by talking to them first. There's also a great resource that the American Psychiatric Association has on their website where they have vetted a lot of these apps. It's an impossible task to keep up with all of them. But if you Google it for the American Psychiatric Association and their app database, you should be able to find it. If not, you can call me or email, and we can certainly send the link. But it's a tremendous problem that I think all of us in this world are really trying to get our heads around. How do we solve it and make it so that we have better tools for helping people sort out these multitude of apps and really pick the best ones.
Not much to add except that a couple of my patients have liked the app Mood Reporter. It's called Mood Reporter, and basically it's very simple. You keep track of your moods and your sleep-wake cycles. It gives you a printout of how your moods are going up and down and how it correlates with your sleep-wake cycle. Something we would do in therapy, and that may cut some time in terms of what you need to do in a session with your therapist.
And I get the luxury, right? I have a lot of nerve. But I also would add, in this conversation, you all have done a great job of touching on what are the things that keep people healthy. And I think in the broader conversation, we do want to keep in mind these concepts of well-being. And if you're doing great, what do you need to keep doing great? If you're starting to backslide, what are the things you need to shore you up? And if you're coming undone, what are some things we can do to put that? So, we talk about my strengths, like kind of a strengths-based thing is also part of the continuum of supports out there. So that's just my 2 cents. Head nodding from the panel.
I know that in this day and age of millennials coming up, the apps and software stuff really seems appealing. And I know there's a lot of people that have apps for weight loss and things like this, but it's only as good as the person that inputs the stuff. Do you guys have a lot of problems with these people that are using apps, maintaining them all the time, and being useful with them, I guess, is what I would say? Because I know my son would never do it, and he's an expert on the computer, so I always worry about that.
Yeah, I mean, I think the retention, people download apps all the time, me being one of them, and I especially check out a lot of the mindfulness type apps, and the stickiness value really matters in terms of whether or not it really aligns with what my values are and what I'm hoping to change or what I'm hoping to gain out of the app. And I think this is part of the issue that just is a larger issue around making sure that tech companies have subject matter experts involved and not just like what Matt referenced for the Samsung VR, a study of 13 people who are probably all relatives of the people who are working on the VR. And so really, I think as we continue to push forward, the website that he mentioned is doing a rigorous job of vetting these things. I think it's also really powerful for a clinician or a psychiatrist or provider to have a conversation with your client around how they want to use the app. I would also add that a lot of apps are starting to recognize that just a stagnant, static, I enter my data doesn't necessarily work. And so building out things like health coaches and people who continue to check in with you and are holding you accountable. You know, Fitbit does the whole like connecting people so you can see how many steps your mom took today and if you compete, you know, so the gamification too. But I think it's I think it's just a larger issue around personalization and starting to hone in on what those apps are that work for people. But I agree, the millennials love the texting if you don't have to answer a phone.
And you then call your mother back and say you didn't do enough steps today?
Let's not go there.
I don't think my family would like that one.
I think we had one, and we'll take one more question, I think. Am I right, Rachel? Yeah, just, this will be our last question. Did somebody get a mic to, somebody, perfect. Great, whoever has a mic wins.
Thank you. I'm the mother of a 37-year-old person with bipolar 1. Benefited from the Sutherland Center greatly. My question kind of goes back to what we were just discussing, is where to get up-to-date information about all these therapies and technologies so that we know where to go to get them. I mean, I've never heard of any of these, so I haven't been aggressively trying either. But I was wondering if the Sutherland Center website could have a page, you know, that kind of keeps people in the loop, so there's one place to find information.
Yeah, we have it's a great idea, and you know, we have a person on our staff who started looking at saying, you know, let me pull together all the research that's out there and put it in one spot on virtual reality, and realize that such a thing doesn't exist, and it's all over, and it's become this, you know, monumentous task for her to do that. So I think just like the American Psychiatric Association has done with the apps, you know, we have to do a better job. It's incumbent upon all of us, you know, in our world, of making sure that people not only find out about this stuff once it's, you know, once we can conclusively say, okay, we feel confident this is working, or if there's an FDA approval issue that it's out there, but to let people know, you know, how stuff's coming along and what's emerging and what's coming down the road, because I think that's really, really important to you know, educate people and make sort of the stuff that we're doing more widely available. So shame on us for not doing a better job of that, but I love the idea of putting links on the Sutherland Center website.
I just add one thing too. You know, getting this information online, I think, is one way to get it. Another way is to go to a meeting of the Depressive and Bipolar Support Alliance, or NAMI, and ask people there, who have you seen? What treatments have you been involved in? Or the Sutherland Center, for that matter. You'll, you know, in the education group, you'll find other relatives. And it's important because you do find on websites lists of providers, for example, who provide CBT. And there are dozens of them, and you won't necessarily know if they're the right ones, how they're trained, whether they see bipolar patients, the whole thing.
So, as was pointed out earlier, I've been around a while, and I've had really remarkable opportunities, like meeting Michelle Obama. But anyway, this is really one of the more extraordinary events I have ever been able to take part in. So I just want to thank you guys for your leadership and your boldness, and I want to thank everybody that was here to participate. You're a great audience. Thank you big time for our panel.
There's a mic here. John, I usually don't use a microphone. Is this okay? Yes. Can you hear me now? So my employee was very, very ill all of a sudden, and she couldn't function. And we really didn't know what was going on, but we had a lot of compassion, and we dealt with it. And she would be laying on the floor in her office in a fetal position, and we'd have to step over and say, hey, where's that file, or whatever it is. And you know, we were really worried and concerned. And shortly thereafter, she was led to, through her psychotherapist and psychiatrist, to the Sutherland Center, and went to the Sutherland series. And because of that, she's still here today, and she swore by it. We also have another employee that's no longer with us, and she was very, very disturbed, and we loved her dearly. She worked directly for me for 15 years as my personal assistant. I treated her like a daughter, and we knew her for over 20 years because she was with another organization, and she would go up and down and round and round. And all of us at our company tried to persuade her to go down and sign up for this Sutherland's series. And she just wouldn't do it. And she would go from psychotherapist to psychiatrist, and she was beyond and off the meds, and she was this beautiful person that could communicate with everybody on the planet except herself. And she did take her own life about 3.5 years ago, and it was very, very sad, and she couldn't do anything. We all had to go kind of therapy to ourselves, in our organization. And then a couple of years ago, my son, my younger son, I have 3 children, and we knew he was going through a hard time. And he actually was we were blessed that he came to us and told us, and he actually indicated that he had suicidal tendencies, and he was very depressed, and he was up and down, and sometimes he'd be so high he could actually fly, it looked like. And we didn't know what to do, and he came home and he said, he found out that our basement apartment was going to be vacant. And he said, can I move here into the house? And I said, well, we really don't know, but we're going to help you out, but on the condition that you're going to go down to the Sutherland Center, and we're going to go through this thing and find out. Sutherland Center helped him out tremendously. We went to the programs, and one of the programs, there was Dr. Alicia, who I think is here, was up there talking because my wife and I and some other friends and my son would come with, we'd all go to those programs, and it was like the most incredible education, and it was empowering to family members that you're so worried you do not know what to do, you do not know where to go. So it really helped us ground and center. And Alicia's up there talking about the 30-year-old moving back in the basement. And my wife and I are looking at each other, we're like, she's talking about us. And so I went up, I got to talk to her, and then there was another family there with the son, and they're saying the same thing. I go, no, you're talking about us. It was very interesting, and I go, the whole thing with the program, with the seminar series, for those of us that are not doctors, and we don't know what to do, but we have to deal with this on a day-to-day basis, the Sutherland Foundation and the Sutherland Seminar Series has, as I've read somewhere, the Sutherland Center is changing lives and patients and families, and it goes way beyond that. And I will always support the Sutherland Foundation and the Center, and thank you very much.
Hello everyone, I'm Jason Kelly, John's son, who you just heard about. And I've been writing and performing music all my life. Trying to be efficient here. And I would say that out of everywhere I've performed all over Denver and all around, this right now here is going to be probably the most meaningful thing I've ever done. And it's kind of emotional. I have a lot I'd like to say about mental behavior, and really like to thank the Sutherland Center for helping me as I was entered into this year and supported by my parents and their basement apartment. And now I'm doing things on my own. I have a little medication, stay on that. It's very helpful. Helps you stay centered and not let the depression drag you down. This song I'm about to sing is called Another Wall, and I wrote it with a friend who lives in Tucson. We're putting an album together. And I'll just let the song speak for itself. I have so much more I could say. desperation. Everyone is waiting, waiting for you to come around. You don't know yourself. Whoa. Come on and lose the doubt, scream it out. You can't find clarity when you're trapped by the weight of your misery. And here I stand with an open hand, divided in your head by the memories of the past you cannot recall. Don't close the door on me or build another wall. Paranoia spreading poison from the inside. I see your guilt in the smoke of a new high. You can't cure the desperation by numbing out the pain. Embrace me until your walls are no more fighting till we've dug down to the core. Everybody's waiting, waiting for you to come around. You don't know yourself. Whoa. Come on and lose the doubt and scream it out. You can't find clarity when you're trapped by the weight of your misery. And here I stand with an open hand, divided in your head by the memories of the past you cannot recall. Don't close the door on me or build another wall. Like shattering pieces we fall apart, withdrawing in shape back in the dark. Alone we fight to escape the pain, the face of the loss driving us insane. We let the systems run our minds, broken to fear, false to time, separating us from grace. Troubles of man lost in space. You really done it, yeah, you really done it. You barricaded yourself in a cage from everybody, knowing that living, following in your silent rage. Everyone is waiting. You can't find clarity when you're trapped by the weight of your misery. And here I stand with an open hand, divided in your head by the memories of the past you cannot recall. Don't close the door on me or build another wall. Thank you guys. You can find me on Facebook and SoundCloud, Jason Kelly Music. Thank you, Sutherland Foundation. Thank you, Bob, for starting it all. Thank you, Bob.
Thank you so much, Jason. You're amazing. You're so courageous. Thank you. So, hi, I'm Rachel Cruz. As Bob mentioned, I am the Executive Director for the Sutherland Center, and I have never spoken in front of a crowd this large, so I'm just going to get that out of the way right now. I'm really nervous, but it's okay because I came prepared. A couple of weeks ago, I read an article that said if I use third-person self-talk, it would really help me, so I'm going to try that right now. Rachel is going to use honesty, integrity, and authenticity to knock your socks off. That's right. And at the end of these 5 minutes, you all are going to be so inspired, you're going to give like crazy. It's true. because Rachel is awesome that way. Yeah. And now Rachel's going to move on because she's really getting annoyed with herself. But seriously, I was driving in this morning and I knew I had to focus on a lot, but I kept getting distracted with thoughts of my dad. Some of you know that my dad has been in the hospital in the Philippines for over a month now. He is fighting progressive pneumonia. And over the past 5 or 6 years, he's also been struggling with Alzheimer's and dementia. And it looks like he's in his final weeks of his life. Right. I love my dad. He has taught me a lot in my lifetime, and even so far away and in the state that he's in, he's still teaching me. I'm remembering that in every moment, I need to focus on what matters most. And right now, we are all here in this room because what matters to us is that we have a common interest in bipolar disorder. So maybe you are a mental health professional, maybe you're a family member or a friend to someone who has the illness, maybe it's close in and you have actually been diagnosed with the illness. It's here, you're here, and that's great. So we are going to focus on the fact that we are all here, and that is what matters. I am really proud of what the Sutherland Center has done. Since 2002, we have helped over 1,700 people. Over 1,100 people have gone to the 8-week seminar series that John was talking about. Our center director, Alicia Bross, has trained 35 grad student therapists, and they are taking their skills and expertise out into the world, not just the United States, but in other countries as well. Most importantly, we have provided evaluation and treatment to over 670 people. It's a lot of people. And each of those people have been able to find new or improved housing. They've been able to gain employment or keep the jobs that they have. Some people have gone back to school and they're doing better in their studies. They've improved their relationship with their family and their friends, and that is so important, as Dr. Miklowitz mentioned. They no longer hurt themselves. They are not acting out in self-destructive ways. So all of these are success stories, and we celebrate them all. So this is where I ask you to give, but before you do, I also want to ask you, did you get information today that you didn't know about before? Did you meet new people and expand your network? Yeah. Don't you think that the Sutherland Center has made a significant and positive impact in our community? Yeah, I agree. Most importantly, though, did you get enough coffee? Especially you folks who came to our event last year, I really want to make up for that today. If you brought one of those mugs with you, your own, grab some more before you leave. So, I really am so proud of what the Sutherland Center has done. And if you answered yes to any of those questions, please give. Take a quick look at the envelope that's sitting at your seat. Just as an example, if you gave $552 today, you'd be investing in almost a year's worth of group therapy for one client. And also consider that today, an anonymous donor has committed to matching your gift 100%. So your gift is actually has twice the power. So go ahead and use your envelope. Oh, also our long-term funder, the Colorado Grant, has agreed to match 25% of your gift. So it's 125% more than what you're about to give. So use the envelope. Go see Emily back there. She's taking credit cards, or go to our website, rdsfoundation.org, and give today though, because that's how we would get the matching gift. So, Rachel thanks you for being here today, and she thanks you in advance for the giant checks that you're about to write. and she hopes that you have a really great day. Thank you so much.